Okay, so let's talk about aspiration. I'm going to end up hurting myself here. Will you make sure you can see that through there? Okay, so what is important about aspiration? And do we have, who are some patients that are at risk for aspiration? Stroke patients. Who else? Post-op. Okay, so post-op patients. Patients with neurological conditions that they may not be able to protect their airway. Okay.
Altered level of consciousness.
So yeah, altered level of consciousness. Somebody that comes in. I can't write and talk at the same time. So somebody that comes in that is maybe under the influence of drugs or alcohol. So they have an altered level of consciousness. So these folks right here, basically you can't protect your airway. So somebody's got to protect it for you. So what do we need to do? We've got to, somebody who is coughing, aspiration is, or low O2 sat is probably going to be a symptom, if you will, of aspiration, okay? So we're going to see low O2 sat. Coughing is going to be an indication that they may aspirate or they have aspirated, okay? So we've got that protective cough reflex, and if that protective cough reflex is not working the way that it should, then they are at risk for aspiration. So then, tachypnea, if they get to the point of blue lips, we have got a real problem. Yeah, you're exactly right. We have a real problem if they've got blue lips. Subjective, shortness of breath, chest pain, and they're telling you that they're having trouble breathing, and you're noting that they're having trouble breathing, okay? So you're watching them. You know, when we've got a patient that comes in that is a stroke patient, we're going to put them NPO. Immediately they're going to go NPO. The same way with a post-op patient. You know, remember a while ago I said with the tonsillitis, and I know Dr. Jones probably talked about post-op patients, but we want to protect their airway. So, you know, when we get them into the recovery room, the first thing we're going to do is raise that head of the bed. We're not going to remove that oral airway until they're awake and alert enough that I know that they can swallow. EGD patients are prime examples. We spray the back of their throat with a numbing medication. Bronchoscopies, they get sprayed with a numbing medicine. So we've got to make sure that they have a gag reflex before we give them anything to drink. If we don't, then they're prime candidates for aspiration. And then that aspiration can lead to pneumonia, and then we've got a whirlwind of problems, okay? Some of the things that we want to look at, diagnostic, is a swallowing evaluation. If it's somebody that's had a stroke or somebody that's got a neurological condition, we want to make sure traumatic brain injuries, they need to have swallowing study. People who have been intubated for long periods of time, or who have had a trach and that trach has been reversed, you want to make sure that they all have swallowing studies and swallowing evaluations with speech therapy before they're given anything by mouth. I know we have a friend that had a car accident, thrown from the vehicle, traumatic brain injury. He was in the hospital for months and months and months, and still has to have thickened liquids because, and has to remember, you know, when he's drinking to hold his head down, turn his head to the side, and then take a drink. Otherwise, he has little mini episodes of aspiration. You know, we're like, we don't want you getting back in the hospital for anything. So, you know, but he's more predisposed because he has had a head injury, and he was ventilated for a long time, okay? Diagnostic, a chest x-ray can show, remember I was talking about consolidation on the chest x-ray, those things can show on there. And then a sputum culture. We all love sputum, don't we? We just talked about how much we love sputum, Kelly. Sputum is Kelly's life. So we're going to listen to lung sounds, and you may hear some crackles in there. They may be diminished. You may hear all kinds of stuff in there. You may hear all kinds of good stuff in there. So you want to get good lung sounds if you think that somebody has aspirated. Now, you may not initially hear, it may take a little while before you hear anything, and then you may hear stuff immediately. So you just want to make sure you've got a good baseline on that patient. If that patient has come in, you've got to get a good baseline assessment. Okay, when I was talking about assessment on the recording, if you haven't listened to that, you need to listen to it, because you've got to get that baseline assessment, or you're not going to know what is changed if they've aspirated. You know, you're not going to know, did that patient already have some crackles because they had COPD, or they had wheezing because they had asthma. You've got to establish that baseline, okay? If they do aspirate, then you're going to give them some antibiotics. Again, remember, what did I say about antibiotics? You don't give them if it's viral, right? But with this, they're going to get an antibiotic if it goes to the place that they got an infection. So, and how are you going to determine if they got an infection? Sputum culture, CBC, fever, all of those signs, symptoms of infection are going to start showing up, okay? They might give them a prophylactic antibiotic if they think that the patient has aspirated. Sometimes these folks come in from home and you don't know, what's going on with them. They may have aspiration pneumonia where they aspirated at home or in the nursing home or something like that, okay? So there's all variations. That's why you can't just say, oh, this and this and this and this. This is happening, okay? So we want to prevent it. So this is interventions, but this is prevention. Okay, so prevention, elevate the head of the bed. We don't give them anything until we know that they can swallow. So once they can swallow and we know it, we want to give them thickened liquids. Is that on there? So thickened liquids. And then soft diet once they can tolerate, okay? Once they're tolerating. Encourage them to take small bites. That's really important. If somebody takes a large bite, they're just like gorging their food, and that does make them at greater risk of aspiration. Patients who have GERD are also a risk for aspiration, especially in the night. My husband actually ate chili this weekend, and he was laying on the couch asleep, and he aspirated a little bit up, and he coughed and coughed and coughed, and I was like, you are getting on my nerves coughing. And he finally said, well, I think I aspirated a little bit of that chili. And I was like, well, that's lovely. Now here we're going to have something else going on with you. Okay, so this one right here, I like that you all put that on there, because if someone is getting tube feeding or enteral feeding, you want to make sure that it is confirmed, that placement is confirmed of the tube before you start the feedings. The head of the bed has got to be elevated. If it's a continuous feeding, then it always has to stay up. If it is not a continuous feeding and they're getting bolus feedings, so they're just getting a feeding at breakfast, lunch, supper time, then they need to maintain the head of the bed at for a certain period of time. And you need to go by your facility policy, what that is. Plus, you need to check gastric residuals before you lay the patient down and make sure that there's nothing left in there that they can aspirate up. The best rule of thumb is to leave that head of the bed elevated to a degree, okay? In education, instruct the patient to sit up when they're eating. Don't use straw. If you've ever had to lay down and eat, you just can't hardly do it. Try to get a heart cath patient to eat a sandwich laying down. They don't like to comply very well. So does anybody have questions about aspiration?
Making sure that placement
Yes, they're going to confirm placement with X-ray. If it's an NG tube, if somebody has an NG tube, because they can feed, we'll get more into that in GI, but they can feed through an NG tube for a short period of time. So that's going to be confirmed with radiology. But if they have a DIPOF put down, they're gonna go most of the time to fluoro, and they're gonna put that in fluoro, and they're gonna determine it. But you also have to confirm placement every so often. So you're gonna listen. You're gonna instill some air into that feeding tube and listen. Now, if you can't hear very well, you don't want to just keep putting air in there, because what are you doing? You're gonna inflate that stomach with air, and then anything that's in there can be regurgitated back up, and they can aspirate it, especially if their airway's not protected well. Okay? All right, questions about that? Anybody? Okay. COPD, we're going to do that in a nutshell. Did I carry your stuff for you?
Oh, I think I can. I've got everything sitting up here. I told them that they were going to be sick whenever I was carrying it, when they're watching it. Some of this light shining on here is it's intimidating to teach some of this stuff in front of a respiratory therapist. Okay.
Okay, so COPD. Now, COPD can encompass a lot of things. It is a chronic obstructive pulmonary disease, and it is not a disease in and of itself. It can encompass many different things. So when we think about COPD, your book kind of talks about emphysema and COPD in two different aspects. Sometimes people group those things together. I didn't have you all to do COPD, and you all can look at those and see what the difference, or I didn't have you do emphysema. You can look at those and see the differences, okay? But
can I put a 2 cents in?
Yes, Kelly is going to put 2
so
cents.
COPD is generally thought of to be emphysema and chronic bronchitis. Asthma is sometimes thrown in there with it, but it's not really a COPD disease. It's generally chronic bronchitis and emphysema. They're two different processes. Chronic bronchitis is a disease by which the patient has a productive cough for at least 5 years in a row for at least 3 to 5 months at a time. Okay. Emphysema is a disease where the patient loses the wall between the alveolar sacs, or the little air sacs in the lung. Once those walls are gone, there is no replacing them. Both of those diseases are lumped into COPD, but they both present very differently. So saying somebody has COPD doesn't really tell you a bunch about a patient, other than the fact that you know that they've got a lung disease. But a lot of those diseases exist together. A lot of your patients with emphysema also have chronic bronchitis. A lot of your chronic bronchitis also have emphysema.
And your book goes into chronic bronchitis, so you all can look at that and read about chronic bronchitis in your book, okay? And it talks about tracheobronchitis, which is different, is very different and distinguishable than between that and COPD, okay? So when we're talking about COPD, we're going to kind of talk about in a generalized format. Is it getting hotter in here, like as the afternoon goes along, or is it just because I'm up and moving? I guess it is. So the nursing diagnosis that they've put in here is airway obstruction, okay? So we do have some kind of an obstruction going on within the airway, all right? Can it be in one specific area of the airway? Kelly can interject, you interject anytime, Kelly.
So one of the things that I find that confuses people is when we talk about airway obstruction, when I first think airway obstruction, I think, oh, some kid inhaled a marble or a peanut okay, when we're talking about COPD obstruction, that's not what we're talking about. We're not talking about a foreign object. The obstruction is the swelling in the actual airway. Okay, so you've got airway edema, then you have increased mucus production. Your subglottic cells and your submucosal cells produce more mucus, so there's mucus in the airway. That's also causing obstruction. And that can happen in specific zones of the lung, or it can happen throughout the lungs. It can be in the small airways, it can be in the medium-sized airways, it can be in the larger airways, but it's all lower airway. We're talking lower airway obstruction, which is below the level of the vocal cords.
Okay. Yes.
So does that mean that like it's different for every COPD patient where that specific?
Yes.
Yes.
It does.
Yes. Yes.
Good question.
Okay. Yeah, that is a good question, because when you listen to lung sounds, they're not all going to sound the same, you know, depending on the area that is involved. And let's see.
And I love the fact that somebody's got PFT under diagnostics, because that is the gold standard for diagnosis for COPD. You cannot truthfully diagnose a patient with COPD without doing the pulmonary function test.
Okay. So right here's the pulmonary function test. So, and your book really goes into specifics about a pulmonary function test and the differences between, you know, what the volumes are, what the inspiratory, the expiratory. It goes into a lot of that. And as far as you as the nurse is concerned, what I want you to know is what you're going to tell the patient, because you're not going to do that pulmonary function test. You're going to collaborate with respiratory therapy, and respiratory therapy is going to do that pulmonary function test. And they're going to work with their pulmonologist and the patient's pulmonologist to determine what the results of those are and what the disease process is. As the nurse, you have to be able to tell the patient what it is that they're going to experience, you know, because they're probably going to get out of breath during this. And, you know, they're going to have to, I've had several pulmonary function tests, and they are not fun. Has anybody in here had a pulmonary function test? A long time ago. So I've had one recently because I was diagnosed with adult onset of asthma. Imagine that. So, you know, when I go in to see my asthma doctor, they want to do a pulmonary function test, and I'm like, oh, I just hate it, because I have to blow, and I'm blowing out the candles, but they're assessing that volume of air in and out of my lungs, and to see if there's any change, which they said mine was good.
I just had one of my friends that had to do that for GE, and they made her do that twice because she was only getting 89%, or like 80%. Like that was as hard. Like she just had a boiler wreck like a few months ago, and she ended up puncturing her lung. It was very small, but still, like whenever they did that, the doctor like brought her back in there and was like, "Do you have like anything?" Like he was like, "I'm gonna need you to do this again," and she wasn't even getting in the 90s.
Oh,
like
wow.
he was pretty concerned about it.
Well, and what I want you all to understand about PFTs too is that these can be used in in health assessments for jobs, because some factories and those kinds of things can cause long-term effects on the lungs. So they want to have a baseline to see if that patient or that employee is where they are, and then if there's any damage that's going on with
Some of our mines now do them as pre-employment physicals as well.
Yeah. So you'll see that done, you know, in a lot of places. If you work in an outpatient clinic, you may see, you may have patients come in, and that's part of their diagnostic testing. Okay, they have a chest X-ray and a pulmonary function test. So we're thinking in terms of our patient has come into the hospital. You know, they probably already know that they've got COPD. When we're talking about an acute care setting, we don't typically, we usually this is a progressive disease that we can't, you know, happens over a period of time. So we see these folks, you know, when we get to clinicals and when we're working on the floor, we're going to see them in the acute care setting, and their health state is going to be debilitated. Okay, so we're going to have to try to return them back to that homeostasis. So what are we looking for on assessment? What do we want to see on assessment? We're going to check their vital signs, and specifically on their vital signs, what are we going to note? Okay, so their O2 sat, and what else?
Respiration,
Okay.
breath sounds, lung sounds.
Okay.
We've got that down further,
Okay.
just in case you don't want to write it.
Okay. So we are at history. Okay, what do you want to ask in the history?
Smoke.
Pre-existing conditions. Smoking is the big thing. Smoking is the big thing. Okay, if they have a cough, if it's productive, if it's worse in the morning, if it's productive, what does it look like? Okay,
How many pillows do you sleep with?
yeah, how many pillows? Because these folks can't sleep lying flat. Okay, most of the time they can't. If it's advanced, especially. So shortness of breath, dyspnea. Is it with exertion, or do they just get short of breath sitting in a chair? Patients who are pulmonary patients, they have to have their activities grouped together. Especially, you know, they don't get up in the mornings and take a bath and wash their hair and take their medicines and do a load of laundry. Especially if they have advanced disease. They need to have their activities grouped, because if they don't, it's going to wear them out. It's going to cause them to breathe harder. It's going to cause more dyspnea. You're going to see them, the workload on their heart's going to be more. So their heart rate's going to be increased. Their blood pressure's going to be increased. Okay? So we want to make sure that, you know, you're doing these good assessments. Listening to those breath sounds. What are they going to sound like? Okay, you may have all kinds of stuff. Diminished breath sounds. You may have some crackles. You may have some wheezes, depending on what's going on with the patient. Remember, Kelly said that, you know, this is kind of under an umbrella, and there's different processes that's going on there. Okay. Are they using accessory muscles? So we want these folks to stay out of the hospital. Our goal is to keep them out of the hospital. But if we can't, then we got to put in place these interventions right here. Frequent oral care, adequate intake, oxygen. So do we want to crank their oxygen up?
No, well, you're not going to have free.
Okay, so
Time out. Time.
I'm glad you said time, because I was getting ready to.
Okay, so,
I'm going to turn this around so they can see who you are.
so COPD patients, don't be afraid to give them oxygen. Don't be afraid to give them more than 2 liters of oxygen. There is only a very small subgroup of COPD patients that over-oxygenation is going to drive or knock out their respiratory drive. Okay? Even those patients, we still treat their hypoxemia. So if they are a chronic hypoventilation CO2 retaining patient, which is that subgroup that everybody's worried about over-oxygenating, and you go into their room and their SAT is 80, I don't care if you put them on a non-rebreather. Put them on a non-rebreather. Get their SAT up to at least 88 to 90%. I don't care who the COPD patient is. You want at least 88 to 90%. Okay? Okay, so everybody gets treated for hypoxemia, even COPD patients, and yes, you can go over 2 liters with them.
Because you don't want to not treat their COPD, because if you don't treat their hypoxemia, if you don't treat it, then what's going to happen?
Their O2 sets are gonna continue to drop, and then you're gonna get in trouble, and they're gonna end up on a ventilator in the ICU.
And COPD patients, once they go on the ventilator, especially, not as much your chronic bronchitic, but your emphysema COPD patients, their life expectancy, once their first time they're on the ventilator, is less than 5 years.
So you wanna avoid ventilator dependency, okay? You wanna avoid that. So some of the meds you're gonna see with these folks is bronchodilators. You're going to be working with respiratory for collaborative care. Respiratory is probably gonna be giving them some neb treatments. They're gonna be listening to them too. But just because respiratory listens to these patients does not excuse you as the nurse from listening to these patients. You need to collaborate with respiratory and say, did you hear such and such? Did I think I'm hearing this in this patient. Collaborate with them, talk to them, have open lines of communication, because we're supposed to be there to work as a team, and you can't do it all on your own. If you're trying to do it all on your own, then you're not doing your patients any favors. Respiratory, I made friends with respiratory real quick on my unit because I worked in intensive care and I don't manage a ventilator. They didn't teach me to manage a ventilator. I could look at the ventilator and know if the settings were appropriate, but as far as managing the ventilator, that's what they went to school for. That many other things, but they manage that ventilator a whole lot better than I can. So, I made friends with the respiratory therapist. They were my buddies because I utilized their resources greatly, and they would always come if I called for them. So, we just want to keep these folks, we want to keep them well hydrated. We want to encourage, if these people are, if they're in an outpatient setting, we can encourage pulmonary rehab. Pulmonary rehab is a great avenue. It can help to improve their breathing pattern. It can help to improve their activity tolerance. And your book talks a lot about pulmonary rehab. There's a couple of pages in there about pulmonary rehab. So if you can look over that to just see, because like she said, when these people get to a debilitated state that they're needing mechanical ventilation, then their outcomes can be a whole lot more poor. So we want to implement all of these interventions before they get to, coughing and exertional dyspnea and those kinds of things. And we want to teach them as the nurse to group those activities together. Pulmonary rehab, we never started pulmonary rehab before 10 o'clock in the morning because those folks just couldn't get there. They could not get there. They were usually too debilitated. It took them a while to get up and get going. And some of the other things we want to teach when we're getting ready to discharge them home is about oxygen therapy at home. Because they need to know how to use their oxygen concentrators or their cylinders, whatever that they have. We want to get respiratory involved in that home teaching with oxygen therapy so that they can reinforce and you can reinforce what they're telling. Both of you can work together. And the patient can see that you're a united front and you're both giving them the same information, okay? So you want to get that teaching in there. Let's see.
One of the other things with them is also nutritional status. A lot of our COPD patients have really poor nutritional status. What is under your diaphragm on the left-hand side? What organ is directly under your diaphragm on the left-hand side? Say it louder. Your stomach. What happens when you eat a full meal? Your stomach pushes up on your diaphragm and you can't take a deep breath. You take somebody with COPD who already has trouble breathing and you give them a full meal and they can't breathe. So they don't eat. They have trouble getting up and fixing their meals because they get dyspnea on exertion. So they can't fix meals, and then when they sit and eat a big meal, then they get short of breath. So teaching them about proper nutritional status, teaching them to do small, frequent meals instead of large meals. That helps them maintain their nutritional status.
Okay, questions about COPD? Kind of a nutshell there, but you know, just look at those patients and look at what they, you know, what they present as, okay? So I'm gonna let Kelly go ahead and talk to you all about that, and then if she wants,
You got TV to finish?
TB and asthma, but we'll do it afterwards.
Okay, so Dawn invited me to talk about respiratory modalities. So I'm gonna give you my quick, fast, and in a hurry, so we